neurosurgery, and I will here try to provide an overview of the development of psychiatric neurosurgery from the early beginning and to the current era. When looking at the archaeological material, it seems as if our ancestors had an almost irresistible desire for making holes in the head in their fellow humans. Trepanations are abundant in many areas around the world and stretches back to the Paleolithic era and survived into modern times, as we see in this video of a trepanation by the Kinsey tribe. But we do not know why they were done. Perhaps the indications were sometimes of a functional nature, like letting out evil spirits causing problems. Later on, during the Roman era, Galen stated that when black bile is accumulated in the ventricles, it can cause epilepsy or melancholy, directly or via its vapors. And Aretaius the Cappadocian recommended trepanations for epilepsy in order to exhale these fumes. And the first time a trepanation is clearly recommended for a psychiatric indication is in the 12th century in Practica Chirurgiae by Roger of Salerno. Here he writes that for mania or melancholy, a cruciate incision is made in the top of the head of the cranium and is penetrated to permit the noxious material to exhale to the outside. And in the art from the 15th century and onwards, extraction of the stone of madness was a popular motive, but this is probably of a purely allegoric nature. During the following centuries, we will now and then meet trepanations for psychiatric disorders, such as in The Anatomy of Melancholy by Robert Burton from 1621. And the development of more modern theories regarding the brain can be said to start with the publication of the Humanae Corporis Fabrica in 1543 by Vesalius. We then see a rapid development, especially during the 19th century, regarding human anatomy, comparative anatomy, histology and pathology. And for our topic, the discovery of electricity is of certain interest, and this field developed rapidly during the 18th century. And this was also the case regarding so-called bioelectricity, and experiments on humans were soon being performed, dead as well as living. Electrical stimulation of the brain on living animals was done as early as 1809, and the first experiments on alive humans around 1870. And even though detailed mappings were done in this manner by Ferrier and others, the most important technique for mapping of the human brain was cerebral localization, where you look at the symptoms of the patient and later at autopsy correlate these changes with changes in various areas of the brain. And we then arrive at the birth of modern neurosurgery in the end of the 19th century, when cerebral localization, general anesthesia, and antisepsis and new techniques made intracerebral procedures possible. An early neuropsychiatric procedure was trepanation with opening of the dura and CSF drainage for general paralysis of the insane in neurosyphilis. But the first intracerebral procedure was introduced by a Swiss psychiatrist, Dr. Gottlieb Burckhardt, in 1891. He operated 6 schizophrenic patients with removal of various cortical areas, chosen quite randomly and with very limited success. However, at this time, the interest had already started to focus on the frontal lobes. And the first frontal lobe procedures with cutting of paretofrontal connections in 3 patients were done in 1910 by Ludwig Pusep and Bechterew, but the outcome was poor and not reported until 1937. Thus, according to the traditional accounts, nothing happened in the field of psychosurgery during the period between 1891 until the introduction of the leucotomy by Egas Moniz in 1936. According to the traditional narrative, Moniz was inspired by the presentation of Carlisle Jacobson on prefrontal lesions in chimpanzees at the Second International Neurological Congress in London in 1935. This story was, however, never endorsed by Moniz himself, who reported that he had informed his assistant, Almeida Lima, of his idea already 2.5 years before he heard a presentation of Jacobson in London. That is, at the time of the meeting of the French Academy of Medicine in 1932. Here, Moniz presented a paper on angiography, and immediately after him, a French psychiatrist named Maurice de Coster presented his cerebral impallidations, and these papers also appeared together in published form. In this, Moniz would have learned that a very large number of patients with various psychiatric conditions, including schizophrenia and mania, had been operated with favorable results using injections into the frontal lobes. Further, that this had been done without any serious complications. Briefly, Ducoster was a psychiatrist working at the asylum of Villejuif in Paris, where he started to operate schizophrenics with mechanical lesions in the 20s, and then turned to injections of malaria-infested blood and other substances. And in 1940, he had operated more than 1,000 patients. He would insert a needle into the frontal lobe using a special device, and up to 5 cubic centimeters was injected, and this would be repeated up to 12 times in staged procedures, which must have created significant lesions in the area. But in 1935, Moniz performed his first operation with the help of Almeida Lima, and in 1936 he presented the leucotomy in 20 patients, and published his paper in 6 different languages, which he sent around the world in order to establish priority. The first leucotomies were made using the same entry point, target, depth, injection technique, and indication as Ducoster, who had by then presented more than 500 patients in 5 publications. The only difference was that Moniz used injections of alcohol and injected both frontal lobes in the same session. Only later would he introduce the core method with mechanical lesions using a leucotome. Of course, Ducoster initiated the Battle of Priority, that was in May 1940, but this ended with a German invasion of France 1 week later. Moniz never acknowledged the work of Ducoster with a single word and received a Nobel Prize in 1949 for his leucotomies. It is today difficult to understand the popularity of the lobotomy, but likewise it is difficult for us to imagine the horrendous state of the psychiatric care before the introduction of antipsychotic drugs in the 50s. Many asylums were overcrowded with severely ill and sometimes uncontrollable patients. To take USA as an example, about half of the beds in the healthcare system was occupied by psychiatric patients, and the budget allotted for these patients was seldom enough to provide a dignified existence. Any suggestion on how to improve the conditions would have been welcome, and no possible therapy was too strange to be considered or too dangerous. Insulin coma, ECT, and even extensive colectomies with a high mortality were used. The leucotomy of Moniz was crude and imprecise, and it is unlikely that this procedure would have become widespread. However, Walter Freeman, working with the young neurosurgeon James Watts, started performing leucotomies in USA already in 1936. But the effect was rather poor, and hence they started to make larger and larger lesions, which resulted in larger and larger side effects. For that reason, they developed a ventriculography-based standard lobotomy, making the procedure less arbitrary. They did also abandon the leucotome and started to cut frontal connections using a blunt blade. And here we see Freeman directing Watts regarding how to make the incisions. Further, in 1942, they published the monography Psychosurgery, where Freeman provided a scientific rationale for the procedure, which was essential for a wider acceptance of the lobotomy. He defined the goal of the lobotomy as to cut the connections between the dorsolateral thalamus and the frontal lobe. And this book resulted in a major surge in the interest for lobotomies. Different procedures were invented, and the most well-known was the ice-pick lobotomy or the transorbital lobotomy, developed by the Italian psychiatrist Mario Fiamberti. This was promoted by Walter Freeman, here seen performing the procedure. The most important reason why he endorsed this method was probably because it could be done by the psychiatrist himself without the need for a neurosurgeon. He toured the country in his lobotomy mobile and performed up to 25 procedures a day and taught other psychiatrists how to do it in half a day. And it is recorded that one of his disciples did actually perform no less than 75 operations in a single day. The transorbital lobotomy looks terrible, but it was probably an improvement compared to the standard lobotomy, both concerning the effects, but especially concerning the side effects. When reading the modern literature on the history of psychiatric neurosurgery, it is not unusual that less well-informed writers assume that the most famous persons behind these procedures were neurosurgeons. In reality, they were most often psychiatrists or neurologists specialized on psychiatric disorders. The second most experienced lobotomist after Freeman was probably the Japanese psychiatrist Sadao Hirose, here seen in visiting the psychiatrist Gösta Relander in Stockholm. It is also interesting as a sign of the spirit of this period to read a paper of the Norwegian psychiatrist and head of Norway's largest mental institution, Ernulf Ødegaard, who wrote in 1953 that psychosurgery can be easily performed by the psychiatrist himself with the tools he might have in his pocket, and strangely enough, it may be harmless and effective. Concerning effects and side effects, it is very difficult today to draw any certain conclusions, but I think that it's safe to say that in the great majority of patients, the trade-off between positive and negative effects was not acceptable by today's standard, but in some of them, it was with yesterday's standard. The side effects of lobotomy were well known in the medical community since the first beginning, and due to the side effects of lobotomy, we see a development towards more selective procedures. And this includes stereotactic functional neurosurgery, introduced by Spiegel and Weisses in 1947. Many of you have probably seen this photo of them performing a procedure in 1948, but almost no one has read the heading under the photo, New Brain Operation for Mental Illness. Stereotactic functional neurosurgery was introduced with the specific intent of reducing the side effects of lobotomy. The first procedure performed was anterior thalamotomy for psychiatric disorders, and here in this paper they reported the results from the 18 first procedures. The target was chosen based on the theories of Walter Freeman, and they were congratulated by him. The most common stereotactic procedures were the cingulotomy, capsulotomy, and tractotomy. And it is perhaps not difficult to understand how these came into existence if one considers that they are all located in the plane where a typical lobotomy would be performed. For historical reasons, cingulotomy was preferred in US and capsulotomy in Europe. The effects of the cingulotomy and capsulotomy are similar, but it seems as if the capsulotomy is more efficient, but also carries a higher risk for side effects. The open cingulotomy was suggested by John Fulton already in 1947 and introduced in 1948 by Lebeau in Paris, but it is most well known thanks to the work of Ballantyne. Talleyrand, who started his career as a psychiatrist, considered the brain to be too important to be left to the neurosurgeons and introduced the open capsulotomy in 1949. And Lars Letzell first introduced the stereotactic capsulotomy in 1952. Concerning the effect, these were reported in 1961 in 116 patients, and about 50% of the patients were said to have a good outcome. Other groups have presented quite varying outcomes, some with very good outcome and few side effects, while others have not been so fortunate. And it is likely that this is to some extent due to differences in the size and location of the lesions, since capsulotomies were mostly done during the pre-MRI era, when the target structure could not be identified with any certainty, and different locations along the whole anterior limb of the internal capsule were used as a target. Jeffrey Knight introduced the stereotactic subchordal tractotomy in 1964, and Laureliten then the subgenual cingulotomy, which is targeting the same area as the tractotomy, but through another approach. And this is actually the most common target for DBS for depression today, the subcingulate area, gyrus area 25. And sometimes a combination of the dorsal cingulotomy and tractotomy was used, named as the limbic leucotomy by the psychiatrist Desmond Kelly. Another less commonly used target was the amygdala. This had been targeted already by Walter Freeman using the transorbital approach and blood injection based on the technique of Maurice Ducoste. The stereotactic amygdalotomy was first introduced by Spiegel and Weiss for epilepsy, but it's more well known from Narabayashi, who used this target for aggressions. And you will find more detailed information in this lecture here. A more common target for the aggressions was the hypothalamic area. Walter Rudolf Hess shared the Nobel Prize with Egas Moniz in 1949 for his animal experiments in the hypothalamus, and the first hypothalamotomy was performed by Spiegel and Weiss in the same year for aggressions. A very simplified view of the hypothalamus might be sufficient for an everyday understanding of the different procedures. There are variations, but there are basically 4 target areas. And the only area used today is the posterior area, which is divided into a medial and a lateral part. The medial area was the most common target for hypothalamotomies introduced by Sano, and is today used mainly in DBS for cluster headache and aggressions. The lateral area is where the medial forebrain bundle and often the limbic STN is targeted or implanted, and it's mainly stimulated in depression and OCD. More anterolateral, we find an area which has been used without much success for obesity. And finally, deeper down, we have the ventromedial or anterior area, which is mainly of historical interest and has been targeted for sexual deviations, hedonia, obesity, and other strange indications. Stereotactic lesional procedures were first used for psychiatric disorders, but it never attained any widespread popularity, but it came to revolutionize the treatment of movement disorders. If we take a step backwards in time, then the first open intracerebral procedure for movement disorders had been performed already in 1890 by Victor Horsley. Later open procedures included Walker's mesencephalic pedunculotomy. Mayers made lesions in the caudate nucleus, the anterior limb of the internal capsule, and of the pallidofugal fibers for Parkinson's disease, while Guillot made lesions in the ansa lenticularis. However, the open procedures had a very high mortality and morbidity, and when stereotactic functional neurosurgery was introduced, this was soon to revolutionize the treatment of movement disorders, starting with pallidal lesions in 1947, followed by the introduction of the thalamotomy in 1954 and the subthalamotomy in 1960. And this was the first effective treatment for Parkinson's disease, and in 1967, more than 25,000 patients had been operated. But then came the decline of stereotactic functional neurosurgery following the introduction of L-DOPA. Very few procedures were performed during the following 2 decades, and this lasted until the reintroduction of Larsleck-Sells posteroventral pallidotomy in Umeå by Lauri Laitinen in 1992. But as early as 1973, a neuro pacemaker had been developed, and the first DBS procedure for pain was performed. Within a few years, the first pioneers applied a new technology also to movement disorders. And the second step in the renaissance for stereotactic functional neurosurgery was, of course, the introduction of modern DBS by Ben Abid and the Grenoble group in 1987. Today, DBS has largely replaced lesions, and we have 33 published indications and 48 targets, more than 15,000 papers on PubMed. But it is important to realize that the situation is the same as with lesions. DBS did not start with movement disorders, but with psychiatric disorders. What I believe to be the first case of deep brain stimulation was performed non-stereotactically in the caudate nucleus by Lawrence Poole in 1948 in a woman with anorexia and depression, and favorable results were reported until the electrode broke after some weeks. Later the same year, he applied the same technique, but to the gyrus singly. Another pioneer in this field was the neurophysiologist José Delgado. He is well known for his animal experiments with brain control, as in the video seen here from the bullfighting arena. But he implanted also humans with psychiatric disorders as early as 1952. The first one to use implanted externalized electrodes for testing outside of the operation theater was the Norwegian psychiatrist and neurophysiologist Carl Wilhelm Sem Jacobsen, who presented this technique in 1953. The Tulane psychiatrist Robert Heath started a chronic stimulation program in the early 1950s, eventually focusing on the pleasure center of the brain and on the circuitry between the septal area and the medial forebrain bundle and the nucleus accumbens. He implanted about 60 patients with up to 29 electrodes in each, and rather strange and questionable experiments were performed. In the video here, we see him talking with a patient who is repeatedly pushing a button and self-stimulating as she describes the pleasurable effects of the stimulation. The first one to use chronic depth electrostimulation as a therapy was, however, Natalia Petrovna Bechtereva, a neurophysiologist in Petersburg or Leningrad. From the late 60s and onwards, her group treated approximately 200 patients with OCD with externalized DBS. The technological development progressed, and the first one to use chronic DBS with a quadrupolar electrode and a neuropacemaker was Gert Dickmann from Saarbrücken in 1979 in a patient with phobia. However, DBS for psychiatric disorders was at this time a marginal phenomenon of very limited impact. And it all ended with the so-called psychosurgery debate. When we discuss this, then it's important to realize that the introduction of stereotactic functional neurosurgery did not result in an abandonment of the lobotomy. It was too expensive and required access to an operation theater, stereotactic equipment, and a dedicated neurosurgeon. In reality, what made the lobotomy subsequently obsolete was the introduction of chlorpromazine in the early 50s. So, modern DBS for movement disorders has been a success story with more than 230,000 implanted patients. And the success for DBS for movement disorders created an interest in the potential of DBS for other conditions, including psychiatric disorders. For pure psychiatric indications, the first publication of interest was the one from Barton-Nutin in 1999 on DBS in the internal capsule. Of importance was also the later publications related to STN DBS, which came to result in DBS in the limbic STN and medial forebrain bundle. And finally, the introduction of subcingulate gyrus DBS for depression by Andres Lozano and Helen Mayberg in 2005. But it is difficult to describe this development only from a temporal perspective, and I will therefore give a more thematic presentation. It was natural that the interest was first focused on OCD, since lesional procedures had proven most effective for this condition, and there were a number of groups performing capsulotomies for OCD around the world. Later, also DBS for depression would be evaluated, and the field of psychiatric DBS has evolved to some extent by serendipitous findings during STN DBS for Parkinson's disease, but mainly by the adaptation of known lesional targets to DBS. And let's start with that route and look first at OCD. So, regarding OCD, we have currently 8 different targets and more than 320 published cases. And it all started with simply implanting an electrode in the same place as where capsulotomies were performed. that is in the anterior part of the internal capsule, but the effects of DBS here was not satisfying. When the location of the electrodes was analyzed, it was noticed that the effect was better further posterior in the internal capsule, while the target was moved in this direction. Some groups have chosen to target the nucleus accumbens. However, it seems as if the effect in the accumbens itself is rather poor, and the effect of stimulation is mostly achieved on the higher contacts located in the internal capsule. Even further posterior, in the inferior thalamic peduncle, the group of Velasco have reported good results, and between these areas is the bed nucleus of Seria terminalis, suggested as a target by Barton and used also by my team. Recently, the group of Lozano published a report on the ITP, but 2 mm more anterior than Velasco. This ITP target must be overlapping with the bed nucleus to a large extent if one looks at the location of the electrodes, and especially if one takes into consideration the size of the volume of neural activation. And considering these large VTAs, it is difficult to know what we are stimulating and what is the best target in this area. And we are probably entering the same or connected networks at different points, and the results are indeed very similar. Thus, I believe that we might have more targets for DBS in the literature than we do in the real world. Let us now move away from the adaptations of old lesional targets to new targets based on serendipitous findings during STN-DBS for Parkinson's disease. Most of what is happening in the human brain is either originating or being perceived in the brain and can hence potentially be affected by DBS. And DBS has provided us with a window to the human brain, and not only a window to look through, but we can reach through this window and affect what is happening on the other side. Even if our intention is to, for example, reduce tremor in Parkinson's disease, we will sometimes encounter unexpected effects. And such unexpected effects becomes more common when we are stimulating outside our intended target. A problem with DBS is that sometimes the electrodes do not end up where intended, but this problem is also an opportunity since it gives us the possibility to investigate other areas of the brain. And serendipitous findings during DBS in the subthalamic nucleus, or STN, in Parkinson's disease has been of certain importance in the development of DBS for psychiatric disorders. Since it was noticed that stimulation-induced hypomania was more common when the electrode was located in or at the side of the anteromedial part of the STN. And in 2002, it was noted in 2 French Parkinsonian patients with STN-DBS and concomitant OCD that stimulation improved also their obsessive-compulsive symptoms, and these electrodes had a very anteromedial location. This led to the French multicenter study of limbic STN-DBS for OCD, published in 2008. This was a blinded crossover study with 17 patients and only 3 months follow-up, and a 41% improvement on OCD, according to Y-box. If you want more details on this procedure, then have a look at a lecture by Karin Karachi. Stimulation-induced hypomania in a Parkinsonian patient with an anteromedially located electrode was also analyzed by Volker Köhnen. He interpreted the phenomenon based on tractography as caused by an activation of the medial forebrain bundle. Based on this, Köhnen introduced the medial forebrain bundle as a target for depression and later also for OCD. And this structure stretches for a long distance and is currently being targeted for OCD, also far away from the area where Köhnen is placing his electrodes. Regarding the limbic STN, positive effects was reported also from the group of Marwan Haris, and it is interesting to note that those stimulating the limbic STN seems to be very close to those stimulating the medial forebrain bundle. The report from London was a comparison between the STN and the nucleus accumbens, and the outcome of these different targets seemed to be similar. We now have 6 randomized double-blinded studies demonstrating a significant effect of the treatment. If we look only at the studies in the area of the internal capsule, then the results after 1 year of treatment seems to be close to 40% reduction of Y-box and a response rate of about 50%. This means that on average, the participants went from suffering from the upper range of severe OCD to the mid-range of moderate OCD. The effect of DBS is thus not instant, but will develop over months and years, and it is not sufficient to look at the results after 1 year. Here is an illustration. We see my first patients with up to 6 years follow-up, and in order to catch also the late responders, we need a longer follow-up. In this review of 249 patients, the improvement was 47% at the last follow-up, and the long-term outcome was nicely summarized in this review of 155 patients followed for at least 36 months, after which the mean improvement was also 47%. Also after this time, half the patients were responders, a quarter partly responders, and another quarter non-responders, a pattern reported already by Lexell for capsulotomies. But let us now continue with DBS for depression, where we have about 9 different targets and 350 implanted patients. This is an estimate on the number of implanted patients and not of published patients, which is of course smaller. And the most important of these targets have a long history and have previously been used for lesional surgery for depression. And most of these targets are the same as used for DBS for OCD. This is quite natural, since the interest in DBS for depression has mainly been fueled by the knowledge that lesional surgery was sometimes effective, and since positive effects were reported on concomitant depression in patients treated with DBS for OCD. Many groups have a preferred target and will use this both for OCD and depression, and this is probably not an expression of the man with a hammer phenomenon, but simply reflecting the same situation as in movement disorders, where we can treat different disorders in the same target and the same symptoms in different targets. Depression and OCD are in the brain networks not as separated as they might be in our artificial classification of the conditions. As we discussed regarding OCD, some of these targets are more or less the same and differ more in name than in actual location of the field of stimulation. And if we limit ourselves to the targets used in more than a handful of patients, then we have basically 3 target areas: the middle forebrain bundle, the area of the internal capsule, and finally the subcallosal cingulate gyrus. The middle forebrain bundle is the 3rd most common target. Less than 30 patients have been published, but promising effects have been demonstrated. In the largest study from 2018, 16 patients were included. Depressive symptoms were reduced with 56% after 12 months. However, this study included a randomization of half the patients to DBS and the other half to sham stimulation, and no difference was seen between these 2 groups, why it might be considered as a failed study. The second most common target is the area of the internal capsule with about 70 patients. This target was chosen mainly based on the positive effects seen on concomitant depressive symptoms and anxiety in patients with OCD treated with DBS in this target. And a number of open studies demonstrated promising results, like this one by Malone with 57% symptom reduction. Unfortunately, also in this target did a randomized multicenter study of 30 patients with sham stimulation fail to demonstrate any superiority of stimulation versus sham stimulation. We then come to the most commonly used target for depression with about 250 implanted patients, the subcallosal cingulate gyrus. And this is actually not used for OCD. This was introduced as a target for DBS by Helen Mayberg and Anders Lozano in 2005 based on PET studies. However, the same area was previously targeted in the subgenual cingulotomies as well as in the subchordal tractotomy. Concerning the results, 64% were responders and 43% in remission at last follow-up after 3.5 years in this non-randomized study. Unfortunately, a multi-center randomized sham control study failed to demonstrate superiority over sham stimulation, but the results from the open phase were better, with a close to 50% response rate. And recently, Mayberg presented the long-term data from 28 patients in a single center study with quite impressive results, as seen here. Further, the same group have stated that in order to identify the optimal target, the gross anatomy is not sufficient. A retrospective connectomic analysis suggested tractography targeting based on 4-bundle convergence of the forceps minor, uncinate fasciculus, cingulum, and frontostriatal fibers. And this was performed in 11 patients, and after 1 year, 9 patients were responders and 6 in remission. This data needs, of course, to be reproduced, but it is indeed most interesting. So, we thus have a number of failed randomized sham-controlled studies of DBS for depression. It is, of course, possible that DBS in these targets does not have a good effect in depression. And here I believe that it might be necessary to point out that most of us who work in this field have seen dramatic effects of DBS in individual patients, which we would be reluctant to ascribe to a placebo effect. However, even if DBS might be effective in individual patients, this does not rule out that the effect on average at the group level might be small, insignificant, and not sufficient to motivate this as a treatment. But there might also be other explanations. The effect of DBS does often take a long time to develop, and I believe that the follow-up time was much too short in these studies, and this was due to unfortunate decisions from the companies sponsoring these studies. Perhaps some electrodes were suboptimally placed when involving less experienced centers, perhaps there were differences in programming, and perhaps the patient selection was of importance. I don't think that anyone knows for sure, but there are some ideas that the internal capsule area might have a stronger effect on anxiety, and that the subcingulate gyrus might have a stronger effect on melancholic symptoms. So the patient selection might be of importance also here. We need further to realize that depression in comparison with OCD is a very heterogenic and complex network disorder rather than a dysfunction of a few specific brain regions. Several different networks are believed to be involved, and here, just as an illustration of the complexity, we have the suggested network for anhedonia. Add to this other symptoms and networks, and the complexity is, at least for me, overwhelming. Samir Chet and his group have perhaps taken this to its logical conclusion by trying to tailor the stimulation to the individual patient's brain. They implanted 4 electrodes for stimulation in the subcingulate gyrus and in the area of the internal capsule, and further 10 electrodes for recording. They then stimulated and recorded the patient's brain during 9 days through 180 contacts and decided which pattern of brain activity was most desirable concerning the patient's condition, and then decided which stimulation parameters would create this pattern of brain activity, and then used this for chronic stimulation, which resulted in remission of symptoms after 18 weeks. Scangos et al. Implanted 10 electrodes for stimulation and recording and found that high gamma activity in the amygdala correlated with severe symptoms, and that stimulation in the area of the right internal capsule would result in a decreased gamma activity in the amygdala with a subsequent symptom reduction. They then implanted a unilateral closed-loop system where high gamma activity recorded in the amygdala will trigger stimulation in the internal capsule, and the patient went into remission after a few months. Both these cases are most impressive, and perhaps this is the future. My only concern would be that it seems awfully complicated. OCD and depression are the most common psychiatric indications for DBS, but there are a number of studies also on other more unusual conditions. In relation to DBS for depression, generalized anxiety disorder has been mentioned in the literature. Considering that DBS has an effect of the anxiety component in both depression and OCD, it would be interesting to study the effect in generalized anxiety disorder more closely. Unfortunately, there are no published studies, but here we see the effect in one of my ongoing studies of BNST DBS, where anxiety was reduced with 53% and depressive symptoms with 66% in 3 patients at last follow-up. So it seems worth to investigate this possible indication further. Lesional procedures and early DBS has been used for addiction, and in modern times, concomitant effects on drug addictions have been reported in several patients treated for OCD, and one small case series have been published on DBS in decumbents with positive effects on alcoholism. There is further one case report on successful DBS for heroin addiction and a recent case series for the same indication, where 5 out of 8 patients had not relapsed after 3 years. In total, 29 patients have been published with DBS for anorexia, and probably a few more since I made these slides. They have been implanted in subcingulate gyrus or the accumbens with somewhat promising results, but this is a complex condition. Sometimes anorexia will be part of OCD, where I've had myself good results, and sometimes it's appearing with severe depression, where I have not had that good results. So there are many different factors to take into consideration. Even more difficult than anorexia is obesity, where DBS in the accumbens, lateral hypothalamus, and ventromedial hypothalamus have been published in 3 reports on a total of 5 patients with very limited success. The medial hypothalamus was Sano's target for hypothalamotomies for aggressions, and this target was rediscovered for DBS by the group of Francini, who reported a favorable outcome in 6 out of 7 patients. And positive results have also been presented by Kuhn, Torres, and others in a small number of patients. However, these are all, or at least mostly, patients who, due to cognitive impairment, cannot themselves consent to this treatment, and I think that we should be careful with this indication. And the same is probably true regarding another rare indication, schizophrenia. It has long been discussed if DBS might be beneficial regarding some of the positive symptoms, such as OCD, and there is now one study of 8 patients with schizophrenia with some positive effects reported. Finally, there is a case report on DBS using the old lesional target in the amygdala for autism, and this target was also used for post-traumatic stress disorder, where a total of 3 cases have now been published. So, to conclude, DBS has revolutionized the treatment of movement disorders. Psychiatric disorders constitute a much larger cost to society than movement disorders, and there is a considerable interest in DBS and promising results, but only a few hundred patients have been published during more than 20 years. And there are probably several reasons for this lack of interest. Perhaps DBS is not as effective in psychiatric conditions as in movement disorders. The results of the treatment cannot be visualized in the same manner as in movement disorders. The patient management is much more complicated, and we are still carrying the historical burden from the lobotomy era. But probably the most important reason is that to a large extent, the neurologists are responsible for the rapid development of DBS for movement disorders. The psychiatrists have not embraced the possibilities of DBS, and DBS will never fly if the psychiatrists are not leading the development. And with that, I end this overview. If you're interested, then your more detailed presentations are available at the Stereotactic Academy at stereotactic.org. This is a free e-learning resource under the auspices of the WSSFN. We have now more than 250 lectures and 20 courses, of which many deals with psychiatric procedures. Thank you for your attention. So I will stop sharing.
Thank you, Professor, for an amazing lecture, spectacular cases, and course in the history of the psychosurgery. It was truly spectacular. Thank you very much for sharing your insights and experience, as well as the bits of history to our audience. I see one question in the chat. If you're not against, I'm going to read it out loud. Adrian Ichim wrote, what is your opinion in regards to research involving DBS for memory disorders?
Well, I think it's very interesting, especially from a historical perspective. I mean, if you look at this, then Anders Lozano used an old target they had tried earlier in the 60s and 70s for obesity and tried to treat the patient for obesity. He had no effect on the eating disorder, but the patient got a better memory. And then he turned this into the stimulation of the fornix and is evaluating this in Alzheimer's disease. Actually, it's quite interesting to look at location of the electrodes because it's more or less the same as BNST DBS, but it has a slightly different trajectory. So actually, we're currently evaluating, starting to evaluate our patients with OCD and BNST DBS to see if they get a better memory, but I don't know the answer yet. Anyhow, what is clear is that in some patients, you seem to get an improvement on memory. But to be honest, I doubt that this will be so pronounced at a group level that this will become a working therapy. But probably will know that within 5 years or so.
Thank you so much for your response. And I see in the audience, Attila Yilmaz. He's a functional neurosurgeon from Turkey. I'd like to, Kamil Hoca, can you unmute him so he can share his thoughts, a comment, or ask a question? We also met in Dubai as well.
Well, I think that I might recall the name Attila Yilmaz, yes. Attila, are you here?
Okay, I sent him to request, but there is no response.
Okay, maybe we can use this time to ask Hüseyin Biçeroğlu, professor. He wrote a couple of questions. Maybe he wants to ask himself. Professor?
Thank you very much. Thank you for your nice presentation, Professor. I have 3 questions, small 3 questions. First one is, what do you think about the frontal caudate fibers? I guess it's very important in cingulotomy and lobotomy procedures. Second one is, do you use the terms of extended amygdala, ventral striatum, and ventral pallidum like Professor Leonard Heimer? And third one is, can you share your knowledge, experience about robotic brainless DBS targeting?
They were difficult questions, and I'm not able to answer them in any satisfactory manner. Yes, I agree with you that probably these fibers are very important, but the role of different fibers, I follow the development now over 25 years, and the more I read, the more confused I get. So to be completely honest with you, I have stopped looking at fibers to a large extent, and I'm looking where people are placing the electrodes. It's a regression to a large extent, but the only thing that makes meaning to me. So I will not try to give you a good answer there. Regarding robotic surgery, I don't know. I mean, my impression is that the accuracy of both procedures are as good. But if you are implanting many electrodes, then you will gain time if you're using a robot. But preparing the robot takes time, so no time will be gained if you're only implanting a couple of electrodes. So if you're going to do like Samir Chet and have about 10 electrodes, then yes, I think that we need robots. But if you're going to do more traditionally surgery, then I think that a simple frame is good enough.
Thank you. Thank you very much.
Thank you very much for your honest response. And before I continue with the chat, I wanted to ask, what do you think, how do cultural and societal attitudes affect the development of psychosurgery? And what is the attitude of the Swedish population towards, yeah.
Well, I think that cultural questions are most important here, because we know that in some countries, psychosurgery is completely forbidden. And that is, of course, due to cultural issues and historical issues. Like, for example, in Japan, it's forbidden. I know it used to be forbidden in Russia. I think that was a decision made by Stalin. It's actually forbidden in Denmark because they did so many lobotomies that they don't want to be associated again with any psychiatric interventions, while other countries are quite open. And here we can take the Dutch example. If you look at the publications of psychosurgery, you will see that many more patients are being operated in the Netherlands than in any other country. And I think that one reason for this is that they have started with euthanasia. They are actively helping people to commit suicide, or actually the doctor is killing them on their own request for various reasons. And that includes for severe psychiatric disorders. And I think what has happened in the Netherlands is that when a patient asks the psychiatrist to kill them, then the psychiatrists think that, well, perhaps we could even try DBS before we kill the patient. So I think that's a reason. In Sweden, I would say that no one is negative really to stereotactic functional neurosurgery, but the psychiatrists are not very interested either. And my own psychiatrist explains this as, for them, it's a fun thing. It's interesting, but they have so many patients and DBS can only help so few of them that for most of them, it's not a serious therapy.
Thank you so much. And now I'll continue with the chat. Adrian Ichim wrote, thank you for such a detailed answer, Professor. The next question is from Temi Okaji. Temi, do you want to ask yourself? He's a future doctor, medical student in Georgia from UK. Yeah. Temi?
Thank you for the lecture. I just wanted to ask, does distractibility play a role in functional neurological movement disorders? And could this suggest psychiatric components like abnormalities in attentional processing and a loss of agency in the patient as possible causes for the development of these disorders?
Distraction ability.
Yes. Yeah. So yeah.
If I understand you correctly, that some of the patients have a partly functional component of their disorder. Yes, I mean, in some patients, we clearly see this. Some of them, often I think, of course, we see the patient with purely functional disorders, and we try not to operate them. But then also, of course, we have some patients that have, for example, essential tremor and Parkinson's disease, but secondary, they develop a partly functional component to this that is quite difficult to reach with DBS, to be honest. So when we meet those patients, we will have a very honest and open discussion with them and explain that we believe that they have this movement disorder, but they also have a functional component. And we will be able to help them only with the other one. The other part, we will not be able to affect with DBS.
Thank you so much. And I see that Professor Attila Yilmaz has raised his hand. Maybe we can unmute him so he can. Yes. Professor?
Attila, you still have the phone muted.
Yeah.
Yes.
Can you hear me right now? Yeah, sorry, I'm at the Chicago airport right now, but I cannot miss the presentation of the Professor Blomstedt. I'm trying to catch my plane, but I want to ask my question too. Thank you so much for a nice presentation. I would like to ask that in movement disorders, if the battery is close to the end of the life of the battery, we can see some symptoms started. For example, tremor can be started, and we can understand that the battery is close to end of the life, and we can change it immediately. But in psychiatric issues, for example, for major depression, if the battery is close to the end of the life, it can be result with worse symptoms. Did you have such these issues before? Or even in some cases, if we change the battery, we cannot have sometimes, especially about changing the battery with another brand. We may see some symptoms is not very well like before. Did you experience such these problems in psychiatric issues too?
Less so, to be honest. It seems as if DBS for psychiatric disorders have a bit more robust effect and more long-lasting effects in most patients, not in all of them. Some patients will actually display an increased level of anxiety or depression at the end of battery life. We have seen that, but most often we catch them before they have reached that point, and we replace the battery. And we have not had any real issues when replacing one brand with another, as in a hybrid system. We have had some problems in patients with movement disorder, but not in psychiatric disorders. So in some manner, they are more difficult in almost any other way, but this is not a large issue. I don't hear you, but
I think
have a
he's
nice flight.
muted again.
Yeah, thank you so much. Thank you, and see you in Istanbul, I hope so.
Yeah.
Thank you, Professor, for your contribution as well. And I see one more question from the functional neurosurgeon from India, Dr. Chira Solanki. Maybe we can unmute him as well so he can ask his question. If not, I can read on behalf of him. Dr. Chira?
Yeah. Hello, Professor. Very good evening.
Oh.
So actually, I just wanted to ask regarding the patients who are suffering from schizophrenia.
Mm-hmm.
So I have, in fact, 2 or 3 patients who are suffering from schizophrenia for last 10, 12 years, and they are not getting benefited from medications, multiple sessions, ECTs, even ketamine, comas, and I mean, what do you say? I mean, any procedure, any medications, they are not responding.
Hmm.
So I was just trying to explore what exactly can be done for those patients. Although there is difficulty from the side of psychiatrists, as we already discussed, getting the clearance from psychiatrists to get this patient undergo this type of procedures.
Hmm.
So what I wanted to ask was, there are a couple of studies, large studies from China.
Yes.
They have considered lesioning of anti-ventral capsule for schizophrenia,
Mm-hmm.
and they have reported promising results. So,
Yeah.
what is your take on those papers, those results, as well as consideration of DBS in such case?
Well, I think that firstly, we have a problem here, and that is that people and journalists and media are very negative concerning making lesions in the head for psychiatric disorders because they associate this with lobotomies. And also, I think that they associate schizophrenia with lobotomy to a higher degree than they do OCD or depression. And we also have the issue of if the patient can really leave an informed consent in some of these patients with schizophrenia. So I think that we need to be careful here. But I know that there have been promising results reported, partly in the study I presented here and also from China, not least from Bomin Sons group. But I have no personal experience, and well, if I had a patient with severe OCD as part of his schizophrenia, then I would be willing to consider DBS or lesion for that matter if I hadn't stopped with them. But in general, I would be careful.
And interestingly, I mean, in a couple of patients who are suffering from schizophrenia, they are also having symptoms of OCD overlapping with schizophrenia. Yeah. So in those cases, I mean, just in case if you want to do something for the patient, then what would be your target? It would be nucleus accumbens, or still you will go ahead with VC?
I would go with the BNST. I don't think that this is better than the internal capsule. And I think that if you aim for the nucleus accumbens, then I don't think that you will have good effect in the accumbens, but I think that this is you will end up with a good location of the higher contacts in the internal capsule. And I think that based on the current knowledge, it's not possible to say which target in this area would be the best, but something in the internal capsule area, including the BNST and accumbens.
Dr. Solanki,
thank you very much, sir.
possible to turn
Yes, sir.
your camera when you are
Yes.
asking the question? Thank you.
Yes. Yeah. Thank you very much, Professor, for the wonderful answer. Yeah. Thank you.
Thank you very much for your question as well. And now I see next question from neurosurgery resident from Astana. Ayman, would you like to ask your question yourself?
Yes, Professor, good evening. You provided such an amazing presentation. It was a very big joy to listen to you, and thank you for answering all the detailed questions in the chat bar. I have more like a clinical patient. We have a patient who is currently in minimal conscious state. I was going to suggest a DBS for him, but currently he has a heart failure with reduced ejection fraction. So I was started to read a VNS, vagus nerve stimulation procedure operation for him. And in such occasion, I was curious if you could share your experience or thoughts in such case. Maybe you had anything.
No, that's very simple. I have no experience. We have been discussing to start a study on minimal conscious state, but those patients in this part of the world, at least, so few that it's almost possible to make a study even if I include the whole of Sweden. But if you go on the Stereotactic Academy, then you will find a very good presentation on DBS for minimal conscious state from Croatia. I think that based on the literature and based on my discussions with Darko Shudi, who has the most experience in the world, I guess that DBS will work in individual patients, but I find it very difficult to make a guess how effective it might be on a group level. So if it's indicated to try it or not.
Okay, but what about VNS? Heart failure?
I have no experience or knowledge about that, unfortunately.
Thank you.
But send an email to Darko Shudi. I'm sure he is happy to give you a good answer.
Thank you. I will do it.
Thank you so much. We have one more question from Adrian Ichim. What is your opinion?
Adrian, maybe want to
And
add?
then he cannot speak, unfortunately, but I will read his question. What is your opinion on complex implants like Neuralink?
Oh, well, Neuralink, I don't know anything about really. Elon Musk is working outside of the Society of Functional Neurosurgeons, so I don't think that we know really what he's doing. I think that sometime in the future, this will probably be realized, but I think that there are many practical problems along the way. So the question today is more about closed loop systems or multiple electrodes and sensing. And I think that, yes, the time is probably right now to evaluate sensing during scientific conditions to see how this might improve. So in the future, we might actually use closed loop systems. But I don't think that it is something we can use really for treatment at this point in time. But it is time to start using them for evaluation.
Thank you so much. Now we have a question from Miraj. We can open mic if it's possible.
Where is Miraj? Miraj, can you open? Can you turn on your camera? So okay.
Okay, can you hear me?
Yes.
Yeah.
So I'm a medical student. I'm a student of Hasan Kamil Surgery in Turkey, and I have a different question. So I don't understand much of the topic as I'm still a student, but I am interested in the. I'm getting more and more interested in the field of reconstructive surgery, whether it to be a plastic or cardiac or neurological. And I believe, or I thought that psychological surgery is more of a niche or experimental field. I always thought such way, and people will always think medical treatments are the first line preferences for the patients with psychological disorders. So what do you think about the future of your field? Do you think will it remain as a niche or an experimental academical field, or it could be a great career choice in the future? What do you think?
Well, I think I would answer yes on both questions. I think that it will be a small niche, and yes, it could be a great career opportunity. If we look at DBS and lesions for that matter, stereotactic functional neurosurgery, then 20 years ago, it was almost all about movement disorders. 10 years ago, it was almost all about movement disorder. And today it is almost all about movement disorders. And I can predict that in 10 years' time, it will be almost all about movement disorders. I think that the DBS for psychiatric disorders, in the future, we will start to use it more often for obsessive-compulsive disorder. It will become an accepted treatment, but it will still be quite few patients, and it will be very few patients compared to Parkinson's disease and tremor and dystonia. Concerning depression, I don't know for sure, but I think that we are ready now to start evaluating this again. We got some sort of backlash after these 3 failed studies 10 years ago. But now we are starting new studies, and I think that in the end, we'll probably find the right patients and the right target, and it will be something that will be used in a number of patients with very severe symptoms that is not responding to any other therapy, but it will still be few patients compared to movement disorders. So if you want many patients, then it's not the right career for you.
Thank you so much, Professor.
Thank you, Professor, for your honest response. Thank you. And I don't see any more questions in the chat, so I have one last question. I asked this question to Konstantin Slavin in Dubai. I come from a developing country where functional neurosurgery is almost non-existent. So I'm interested, what would be your advice to young neurosurgeons who are willing to hone their expertise in this field? How would you advise them?
Well, I would advise them to go on the Stereotactic Academy if they're interested in this field, because now we are gathering more and more experience. I mean, I trained in the traditional way. I was standing with my mentor, Marwan, and scratching my head and trying to understand what he was doing. And then he would explain to me, and often I did not understand, and so on, and it took a long time. Now we are trying here. Of course, you need a good mentor, but it's also very helpful to have a structured and simplified education online. And now most of the answers are provided in these lectures by many of the best surgeons in the world. So go to the Stereotactic Academy and have a look at the material. And we are now starting also to go into the field of pain, and we'll move on with the WSSFN also into other areas, try to provide a rather complete theoretical education online in the end, I hope.
Thank you so much. I see that Professor Chirag has risen his hand. Kamil Hoca, maybe? Okay.
As Professor, I just wanted to ask you a question. Probably it might not be related to our topic of psychosurgery, but in general, related to stereotactic and functional neurosurgery, as we know that after the invention of L-DOPA, psychosurgery went down. Initially, we were doing lesioning procedures. After the invention of DBS, it replaced lesioning procedures. Now, what is your take whether the invention, whether the rise of focused ultrasound, is it going to replace DBS by any means in near future?
No. I'm currently trying to go into and understand the studies on focused ultrasound in detail, because I'm buying one now, I hope. And what I see is that if you really look at the results of focused ultrasound for essential tremor, then I don't think that these can compare really with those of DBS. I think this is a good treatment for those patients that are very old or frail. And I think also if you can't accept the idea of having implants, then yeah, it seems to be a rather good effect if you can accept the risk of some permanent side effects. So I think for essential tremor, yes, it's here to stay, and yes, it's a good option for part of the patient population. Also, some patients with Parkinson's disease who are have mainly tremor, they might be candidates. For psychosurgery, the experience is very limited still, but I guess that capsulotomy might be an option here. And to be honest, I think that if we look at the literature, there is no indication that DBS in the internal capsule area is better than capsulotomies. I think that actually, in my experience, I had better outcome when I did capsulotomies than when doing DBS. And it's simple, it's cheap, and yeah, so I guess that focused ultrasound might be an option also here. But if not, well, radio frequency lesions will work fine.
Thank you, sir.
Thank you, Professor. I think we had really fruitful discussion. Different questions, and lecture was amazing. Kamil Hoca, maybe you would like to add a comment?
I want to thank again to Professor Blomstedt, and we also had Marwan Haris once a time before, and this is also an amazing lecture. We have 49 participants at most in the lecture, but it was quite international lecture. We have many people from Turkey, like me, apparently, and Georgia, India, Romania, United Kingdom, Kazakhstan, and I don't know, maybe the others. I am happy for that. And I want to thank again to Professor and to everyone who joined us today.
Thank you. It was truly international conference. Thank you, Professor, once again. And thank you for the audience for their contributions as well.
Thank you so much.